So good evening once again, everyone, and welcome to part 7 of the Beautification webinar series. So this is the last part, which we've been doing now every week for the last 7 weeks. And this is probably going to be one of the most interesting ones, and surely probably one where a lot of you will have a lot of questions. So it's all to do with managing and avoiding complications within facial aesthetics. Now, I normally run a course as part of the Academy of Aesthetic Medicine, which some of you are following on YouTube and Facebook, and my complications course is normally a day long. So, you know, I'm not going to be going into too much detail in this webinar. It's probably going to take me about 30 or 40 minutes to go through today, but do appreciate that we're talking around 6-7 hours worth of content being broken down just into 30 to 40 minutes. So, you know, I've just tried to pick out the main things, and we'll take it from there. So without further ado, let's make a start. So what will I be talking about this evening? Well, a general insight into complications. Now, there's a lot of complications that can occur, as you'll see, but I'm not going to be going into the actual diagnosis and treatment planning for every single one. Like I said, I'd be here all day. We'll talk about managing certain complications. Again, a very brief overview, and how we would avoid complications, and then a few common myths that we all have probably heard within various parts of the industry. So that's things like needle versus cannula, should we aspirate, and you know, what is a high risk area, what is a low risk area. Now, everything in this in this webinar is all evidence based, so you'll see the references. So there's nothing that I ever teach which is you know, just a random fact, so to speak, unless I tell you it is. So everything will be evidence based here. So I'm sure some of you will be surprised by some of the facts. So a quick introduction, and obviously not many words on this slide, as you can see, but this is the ultimatum when it comes to diagnosing and managing complications in facial aesthetics. And if you look at this picture of this lady here, you can see that there's obvious necrosis here, likely in the supratrochlear, supraorbital region, and you can see that this visual disturbance was a little bit of ptosis, as well as deviation of the eyeball, as well as edema. So this is something that we would call ophthalmoplegia, which is typically associated with blindness, which we'll talk about later on. So I'll cover blindness towards the end. So moving on from an introduction point of view, there are certain safety rules which I would like to implement in practice. Very basic, keep it very simple, and it's the PAMP or the PAMP. So the first thing is the patient. And if you have the wrong patient, you know, so you're not doing your actual treatment planning stage correctly, then the chances of you having that adverse event will be higher. And, you know, this is a type of patient, for example, who's very aged. And let's take the perioral region as an example. You feel that you need excess product to create that lift, to diminish the folds. You put more product, higher risk of nodules and migration, etc. So, you know, the patient is very important. And obviously, the initial consultation, as well as the treatment planning process, it plays a huge role in terms of trying to minimize the risk. The amount of product, which I've almost kind of covered, method and product. So, you know, keep PAMP in the back of your mind. So trying to minimize complications here. So have the right patient, always use the right amount of product. Without a doubt, the chin and cheeks in particular, they can take, you know, 1, 2, 3 syringes of product, but it doesn't mean you go whack the whole amount in just to get that wow factor. So, you know, there's a reason we say less is more. You know, so smaller aliquots, smaller amount of product, and you're likely to be safer and minimize that risk of complications. The method, which we will talk about later on, this basically means whether it's going to be a needle, whether it's going to be a cannula. And so that's another argument in itself. And product, you know, using the right product. A lot of you have probably seen a set of lips which are extremely lumpy, or they've got a lot of nodules in them. Well, clearly it's the wrong product, possibly in the wrong place, and injected badly. So these 4 things, when put together, will help minimize the risk of having that complication. So pre-treatment screening. So this is basically just like being in a hospital or in a dental practice or wherever it is some of you work, and you're taking that history, and it's a very basic format. It's nothing that we're doing anything extra. The main thing that we're adding on, as you'll see at the bottom here, is the aesthetic history. So just recapping this side, your medical history, are you on any certain medication, warfarin, apixaban, rivaroxaban, anticoagulants? Do you have any allergies, which is important in case we ever do need to use hyaluronidase or lidocaine? Pregnancy, breastfeeding, and aesthetic history. The last one is very important. And for me personally, I tend to ask where they've gone for their previous treatment and how long ago it was. And, this one's probably very poorly answered by patients, but what products were used? The last thing you want is somebody to, for example, use product X, they come to you 3 weeks later and you end up using product Y, and then they end up having a complication, let's say a granuloma down the line. It's difficult to know what exactly has caused that. So usually we would say there has to be some form of delay between mixing products within the face. But aesthetic history is very important. Product selection, I'm just going to run through this slide extremely quickly, but this kind of goes without saying. And there's various brands out there, all who have their own reps, and they will all be saying very similar things. That it's biodegradable, there's not a lot of migration in the products, it's not harmful, and these are the characteristics that you are wanting them to say. But from a clinician point of view, things that we also need to consider is things like the G prime of the product, so how thick and solid the product is, how much lifting capacity it has, and the cohesivity of the product, so how well it sticks to wherever you've injected. So let's try and summarize complications. And this is something that whether it's used elsewhere, I'm not sure, but this is the way I would devise complications. And some of you may just dive straight into it. For example, if I say, what are the complications in facial aesthetics? Oh, we get granulomas, we get vascular occlusions, we get lumps and nodules, etc. But just like working in the NHS or in a hospital environment, have a systematic approach. So this type of classification is very basic, and this is essentially acute and chronic. So you're trying to devise and narrow down the complication that you're dealing with. So is it acute? And if it's acute, what kind of things would we be dealing with? For example, an allergic reaction, a viral infection, asymmetry, edema, erythema, etc., and even embolism. Now, not all cases of embolism or necrosis, etc., will happen within seconds or within minutes. Sometimes you can get a delayed vascular occlusion as well, which will happen 2 or 3 days later. But again, it's still a nice classification where you can put them into 2 groups, acute and chronic, and things that will fall in the chronic group would be things like granulomas and nodules. And this is a little bit more of a detailed classification whereby we have trauma, and I will be covering all of these one by one: nervous complications, lymphatic complications, infectious complications, inflammatory, and vascular complications. So, the first thing when your patient has a complication is try and decide which one of these categories it fits into, because they're all treated differently. Okay, so don't just rush straight in. Discoloration is also another one. So let's look at them each one by one. So what falls under the trauma category? So you've got a needle in your hand or a cannula, and you're creating a puncture site and you're entering the face. So there's likely to be bruising, a bit of edema, and erythema. So these things are the initial traumatic signs and symptoms that the patient may experience. Things like bruising, we certainly can give things like amla cream or tablets. Swelling, ice packs tend to help. And erythema, which is redness, this tends to be related to the actual injection itself and tends to be post-treatment and tends to be self-limiting. So now we'll look at the nervous complications. So these are kind of symptoms that you will potentially be able to derive from your patient, such as pain, or there may not be any pain whatsoever, so there's sensory loss, neuropraxia, which is nerve damage, and facial palsy. So this is why it's very important to understand the 5 branches of the facial nerve, because then you'll know, you know, what you've damaged, and if there's any other aspects that that nerve is supplying, whether it's motor or sensory, you'll be able to, you know, see if the patient has those symptoms. So I'm not going to be talking about anatomy in probably not a lot at all, to be fair with you, this evening, because I've done it quite a lot in the last few webinars. So the lymphatic system, so we can get edema, tear incontinence, mucoceles, and cysts. Edema is going to be something that's very commonly seen, especially in the periorbital region. I'm sure some of you would have done, and I definitely have, where you're filling in the tear trough region or the infraorbital region, and the patient ends up slightly edematous. And, you know, this is probably going to be due to lymphatic insufficiency, and usually is self-limiting. However, if things are not limiting, there are certain treatments that we can do. For example, hyalase, try and get rid of the product completely if it is a hyaluronic acid. Furosemide may help, lymphatic massage, and last case, referral to our colleagues for surgical stenting. Infection. So this obviously is quite a large topic, and it will include things like cellulitis or a biofilm, and it could be bacterial, it could be viral, for example, herpes, and even abscesses. So it's very important that infection control is paramount. And if you end up having any one of these, your treatment plan is pretty much going to be considering one of these. So antibiotics, antivirals, microscopy, and incision and drainage if it's an abscess. So I haven't given choice of antibiotics here because a lot of you are watching from various parts of the world. So that's probably some homework for you guys to do. And I know we're not going to all be sharing the same protocols. And infection control. So this is moving on from the previous slide. So making sure you've got that sterile technique, the clean environment, chlorhexidine, you know, changing needles as often as you can. And some practitioners will even argue prophylactic antibiotics or prophylactic measures. And this tends to be reserved for those slightly more aggressive treatments, for example, PDO threats. Immune or inflammatory complications. So these will consist of things like having an allergy or hypersensitivity, autoimmune disease, whether it's rheumatoid arthritis or immunocompromised, and even delayed inflammation. And if you are having an immune response or an inflammatory response, again, antibiotics are going to be something to consider, antihistamines, and definitely steroids, whether the oral, intramuscular, intravenous is another scenario, but steroids are something that's going to be very useful in inflammatory conditions. And before I move on to the next slide, inflammatory conditions, if some of you may be able to think of it as you get nodules. So you'll have inflammatory nodules and then you have non-inflammatory nodules, and they are both going to be managed slightly differently. But this is the mainstay of treatment. And vascular complications. So what are the signs and symptoms of the clinical features? So things like pain, pallor, purpura, pustules, and eventually ischemia and necrosis. So these are just a very generic signs and symptoms when it comes to vascular problems, but we'll talk about vascular occlusions later on. And some of you are using non-hyaluronic acid-based fillers, for example, polyl-lactic acid or calcium hydroxyapatite. And what you'll find is that nodules tend to be the most common type of complication in these fillers. And your mainstay of treatment will be intralesional saline to try and redistribute the product, and intralesional steroids. Remember, non-HA-based fillers aren't going to be responding to hyaluronidase. So let's look at the emergency toolkit, and these are things that I believe you should definitely be having in your kit, and if you don't, you shouldn't really be touching a patient's face with a needle. So hyaluronidase, this goes without saying, and if you don't have this in your kit, that will be considered malpractice, and this is your antidote. When something goes wrong with HA filler, knowing that you've got that or a few vials of this in your medical fridge is going to be the be-all and end-all. So make sure you have hyalase and make sure you have aspirin. And aspirin has a very important role, because if you think of it, if you have a filler that's clogged an artery, then you're going to have stagnant blood flow behind this, so proximal to the filler, and that's going to end up building up as an embolus. So what good is hyalasing the filler, and the embolus that was behind the filler then moves distally and then goes and dislodges in another arteriole. So the whole principle is a bit like treating an MI, is give high dose aspirin, whether it's 300 milligrams, 325 milligrams. I don't think personally it's going to make too much of a clinical difference, but high dose aspirin is going to be pretty much your first line measure, along with hot, warm compress and vigorous massage. Topical GTN, this is very controversial when it comes to managing complications that are vascular, because some practitioners will argue it's better to use a systemic vasodilator, for example, sildenafil, or commonly known as Viagra, or we've got topical, and you know, both have pros and cons, but it's nonetheless useful to keep in your kit. Antibiotics are obviously going to be beneficial, or at least a script where you can write it and you get access to it fairly soon. Steroids, again, oral, intralesional. Antihistamines, if you are having the allergic reaction. Warm compress, obviously the compress isn't going to be warm in the kit, but you know, having a compress and being able to warm it, and a bacterial culture kit, because when you have a nodule, we have no idea what this is, especially when it's inflammatory, because it could be a granuloma, it could be a biofilm, and the one way that you're going to know what it is by taking cultures, sending this off to a lab, and getting a histological analysis. And then that way you can actually tailor the treatment, whether it's steroids or antibiotics, for that particular type of nodule, because they are treated slightly differently. And this is probably very important, and it's basically having some contacts for when you cannot deal with that certain emergency. You know, where I am based here in the UK, you know, there's a lot of practitioners that I teach. A lot of them have my contact number, and you know, they'll get in touch with me when they have a complication, and that's useful. That's good, because they know they've got someone to go to, and I definitely recommend this. You know, and if you think of your worst day on earth, you've injected somebody in the lips, you think you've done a great job, and all of a sudden 4 or 5 hours later the vision is going a little bit hazy and blurry. You're going to want to be getting in touch with someone, because you're not going to be doing any retrobulbar injections. So it's nice to have pre-arranged phone numbers, whether it's somebody who's taught you, or whether it's a local hospital. So plastics, MaxFax, and ophthalmology are going to be your main ones. So let's look at a vascular occlusion, and we'll look at this in a little bit more detail. And here what you'll see is a classic picture of an iceberg, and a lot of the occlusions that have occurred across the world are hugely underreported. So, you know, what we see in the literature is basically the tip of the iceberg. Without a shadow of a doubt, there's a lot more of these complications that are occurring. Off the top of my head, I believe it was back in 2002 when the first vascular occlusion was reported in the medical journals. Now, 2002, what's that? 18 years ago. Back then, they very clearly stated this is an extremely rare outcome. But move fast forwarding now, by 18 years, it's not as rare as it's been made out to be in the past. So, you know, blindness and vascular occlusions, they do occur, but again, they are hugely underreported. And how exactly do they occur? Well, look at this very basic analogy. And if you look at this tree, this is your large vessel down here, your main trunk. Okay, this could be your angular artery, for example. And as you comes up, the filler, you've injected the filler in, so it's intravascular. It will move distally, and then it's got so many paths that they can travel down. And for example, it may come up this way and then dislodge over here. So where are you going to see your signs and symptoms? In this section of the face. Okay, so that's a basic analogy, and we'll cover this in a little bit more detail. So intravascular versus extravascular. So I'm sure some of you have been taught by whoever, and they've said, well, you can have a vascular occlusion, and there's two types that you can have. It's one where you're intravascular, so the filler is within the artery, and the other is if it's extravascular. So basically the filler is alongside the artery and it's compressing it, so there's no blood flow going through. But let's look at this study. It wasn't done that long ago, only in 2016, and they concluded that extravascular compression could not cause vascular necrosis of the skin. So in other words, If a filler is next to the vessel and not inside the vessel, it is not going to cause a sinister vascular occlusion. And you're definitely not going to be losing your vision from it. I'm yet to see that being reported in the literature where somebody has lost their vision because a filler is extravascular. Yeah, you may have some mild compression of the vessel. What can you do? If you begin to see signs or symptoms, or the patient experiences signs and symptoms, then some gentle massage, worst case, vigorous massage, a little bit of heat, dissipate the product, your compression is gone. So if you're gonna have a vascular occlusion, guess what? It's going to be intravascular. And I've had a couple of colleagues that have shown me some pictures of patients, some, I'm gonna say beautiful pictures, but they're actually very nasty pictures of VOs. And you know, they were adamant it's from external compression. No chance, okay? It's just not gonna happen. So, you know, keeping in theme with this paper, which was done by Chang et al., like I said, only in 2016, if you have a vascular compromise, guess what? It's because you have an embolism. And this will be a little bit more clear, I think, in the next slide. And there's no such thing as compartment syndrome in the face. So compartment syndrome is when you get excess pressure buildup within a tissue, and there's nowhere for that pressure to go, and therefore you need emergency surgery, fasciotomy, and that typically happens in the limbs, but there's no compartments in the face per se. Therefore, you're not going to have an external compression, which is going to lead to blindness. And I think, yeah, so here's a good diagram. So if you look at this diagram, this is your external carotid artery down here, huge artery. As it comes into the face, the inferior border of the mandible, and then approximately a centimeter anterior to the anterior border of the masseter is your facial artery over here. And as you go up near the alar base, it becomes your angular artery. So let's say you've injected the angular artery. Where will the product flow? So commonly people think as you inject into this artery, let's say here in the angular artery, the product is going to continue going forward distally, but that's not what happens. What happens to the product is it travels proximally, which means it goes backwards. So if my needle is here in the angular artery, as I'm injecting the angular artery, right, as I'm pressing down on the plunger, the product is moving backwards because the lumen is wider. This is an actual law of physics called Poiseuille's law, very complicated formula, but that's what it's called, and product's going to move backwards. But the moment I stop pressing on the plunger, guess what happens to the product? It then moves distally, so forwards, with the blood flow. Now, so let's say I've injected the product here, it's coming backwards, it's coming backwards, it's coming backwards, and then I let go of the plunger here, it will then shoot forwards this way, or it could come back this way, and then, you know, it can take any path that it wishes, which we do not know. That's why an injection that's going wrong in the lips, so if you're in the superior labii artery, as you're injecting, the product travels proximally, and it's back in the facial artery, and as you let go of the plunger, where's it going to go? Forwards, but it's going to go up the angular artery because it's a lot wider. And then from there on, it may lodge into the lateral nasal artery. And that's why from a lip injection, a couple of days later, you will be able to see a small patch of necrosis on the tip of the nose. So that's basically, in a nutshell, how it all happens. And here is a beautiful diagram from the same study done by Chang in 2016. And this is, if you look at the diagram, so here's a vessel. Okay, this D stands for the distal end, and this is the proximal end over here. So let's just say that this is the angular artery. So where this black arrow is, can you see the white here? This is hyaluronic acid. So this is the gel. And if you look at these two stars, white stars, behind the gel, remember this is distal, what do you see here? A dark red substance. And so what is that? That's your clot, which is an embolism. So what happens when you have a vascular occlusion is you basically obstruct the lumen with the hyaluronic acid, but behind this, always behind this, what are you left with? An actual embolism. Okay, similar type of things that cause strokes and heart attacks. And so this is why we need to give aspirin, because there's no point getting rid of this with Hyalase and then this dislodging even further. Okay, so we need to make sure that we're managing them together. So there was a nice study done back in 2015, and I'm sure a lot of you have definitely seen this picture before, done by Katie Belesne and colleagues in 2015, and they reported 98 cases of blindness. And this was worldwide. Okay, so back in 2015, this is so 5 years ago, there were 98 cases of blindness, and the most common areas were the glabella region and the nose and the nasolabial fold and then forehead. And it was fat. You know, almost half of these visual disturbances in 2015 were because of fat transfer, so autologous fat. And the most common symptoms that they were experiencing was vision loss, which is accompanied by severe pain. And then fast forwarding from this image to this image, which is done just last year. So 4 years later, they have reported a further 48 cases. So there was 98 in 2015, and there's now, since last year, an extra 48 new cases of partial or complete vision loss. And this time, it's the nose that was a higher risk, the highest area of complications, and then the glabella. Whereas in 2015, it was the other way around. And remember I said in 2015, almost 50% of the cases was fat. Well, from last year, of these 48 cases, just over 80% was from hyaluronic acid. And the most common symptoms were vision loss, pain, ophthalmoplegia, and ptosis. A bit like the image that I showed you right at the beginning of this webinar. Now, that was obviously 98 back in 2015, 48 last year. But as I showed you that picture of the iceberg, this is just the tip of the iceberg. And there's, without a shadow of a doubt, a lot more that is not reported. So what are the clinical features that we're going to see when we are having a vascular occlusion? Remember, not all lead to blindness, okay? And you do have some time on your hands to diagnose and have a treatment plan. Okay, so, you know, being a good injector is also about recognizing that you've had a complication, not just brushing it off and thinking, oh, is it a bruise? Is it not? Is it a hematoma? Is it the start of an occlusion? Is it venous? Is it arterial? No, you need to be able to recognize and then treat. Okay, so blanching. One of the first signs that you're going to see when you have an arterial vascular occlusion. Now, this often doesn't last very long, so you need to be really on the ball, which is why I always say when injecting, where should you be looking? Always at the skin. Never look at the syringe. You know, don't waste time looking at the syringe. Yeah, sometimes you need to check how much you're injecting. That's where you quickly glance at the syringe, but you should be injecting very slowly with the least amount of pressure. Okay, it's a very important word here, pressure. Pain. So along with the blanching, you'll begin to get pain. Now, there's another debate. Do you use, for example, dental blocks when it comes to doing lip injections? Because if they have a vascular occlusion, you're masking the pain element. And that's another debate for itself. So if any of you have any questions regarding that, we can talk about that towards the end. But pain in general is there during a vascular occlusion, and it's normally out of proportion. You know, so what I find, what a good thing to ask the patient sometimes is, you know, after your first injection, let's say in the lips, because the lips are very common, we all do lips, what's the pain score after your first injection? 1, 2, 3, cool. You know, halfway through, what's the pain score? And when you finish, before they leave your clinic, again, what is the pain score? You know, and if it's hovered around 1, 2, 3 throughout the whole procedure, you know, you're likely to be fine. But when it goes from 1 or 2, and all of a sudden halfway through, it's at an 11, then, you know, you may have done something wrong, provided you're seeing other signs and symptoms too. Color changes is very important. And, you know, there's certain things that we do need to look for example, like livedo reticularis, and just other generic changes in skin color. And finally, keep this in your head, you can reverse ischemia, but you cannot reverse necrosis. So, you know, by the time, you know, the area goes black and dusky, you're not going to be able to reverse that. That's going to be needing some surgical intervention, grafting, etc. But if it's ischemia, you can reverse this. And think of it like a stroke. You know, when you have a stroke, there's a part of the brain which can be reversed. I might be wrong in saying this. I'm not a stroke doctor by any stretch of means, but I think it's called a penumbra or penumbra. And that's an area that tends to be able, that you can reverse. But when it perseveres into necrosis, you can't. So ischemia does not happen within seconds or within minutes. So you have time on your hands. And there have been cases, from my personal experience, whereby patients have been injected on day 1, and I've seen them with all the signs and all the symptoms on day 2 or even day 3, and I've still managed to reverse everything back to normal. So, you know, I'm not saying that's always that's going to happen. I'm not saying if somebody has certain signs and symptoms, you say to them, look, I'm on holiday, I'll see you next week. No, you know, get to the patient, face-to-face review, get a diagnosis, and then form a management plan. So as I said earlier on, recognition is just as important as actual treating the complication. And without saying too much, you know, certain vascular occlusions can look like other complications. You know, for example, look like a nasty herpes virus, you know, so making sure you're definitely treating the right thing is very important. Because the last thing you want to be doing is, if they have a very herpetic clinical look, then, you know, you don't want to be putting needles into the face and then potentially spreading the pathogen. The antidote, as I said earlier on, is hyaluronidase. This is what we have here in the United Kingdom. Comes in a 1500 unit ampule. Now, I believe it may be different for various parts of in various parts of the world, but this is what we use here. And in terms of treatment protocols, again, I won't be giving away too much, because at the end of the day, I do run complication courses, and, you know, my job here today is just give you an insight into managing complications and things to consider, not necessarily spoon feed you and say, look, this is what you do, 1, 2, 3, 4, 5. But, you know, hopefully this all puts things into perspective for you. So if you look at this protocol, again, from that same paper that was done in 2016 by Chang et al., he's used a few different protocols. So if you take a look at the top left here, he has used hyalase with urokinase, and you can see that from 0 minutes to 45 minutes later, there's reperfusion of the blood vessel. If he only used hyalase, you can see it's fully occluded here, it's very lightly colored, and you can see 45 minutes later that there is still an embolus, but there has been some resolution. And here, if it's just urokinase that was used, again, occlusion, and it's resolved. But there was still a bit of an embolus. And if you look here on the bottom right, what you'll see is saline was used, and there's no real effect. So you can see there's still this bluish tinge where the filler is, and it's still pretty much looking the same here. So he was just trialing different things, hyalase with urokinase, with saline, and that was his outcome. And this is something that some of you probably have heard of, and what is now the so-called mainstay of treating a vascular occlusion, which is called the new high-dose pulsed hyaluronidase protocol. Now, this basically was suggested, I forgot the doctor's name now, it begins with D, but this was suggested to essentially use high amounts of hyaluronidase in short bursts every hour until the signs and symptoms of ischemia have gone. Okay, so this is when there's no more pain left, that the color is beginning to look a little bit more normal. There's good capillary refill as well. So, you know, you're going to be basically hyalasing with a high dose, depending on what you have, wherever you are in the world, every hour until you see symptoms really resolve. So what are the high risk and the low risk areas? And you'll notice here in the title, it says higher and lower. There is no low risk area in the face, and there's no, well, there's plenty of high risk in the face, but there's no low risk. So hence the higher and the lower risk. So very nice diagram here. You'll be able to see here it's highlighted certain areas in green on both profile and facial view. So the temples, the medial part of the face as well, whether it's the nose, paranasal, alar region, and the periorbital region. But these are your very higher risk areas. So fillers in the glabellar region for the frown lines or your superficial 11 lines. Remember, the supratrochlear lies deep. Therefore, if you're going to fill the frown lines, the glabellar region, you want to be superficial. Temples, a very high risk area. A couple of methods to do the temples. You can either use a cannula, so you're going to be relatively more superficial, or you can use the what we call the gunshot technique, the one up and one across. And this is going down into periosteum, but you do need to be aware that the temporalis muscle is stuck on periosteum, and within the muscle itself, you have the deep temporal artery. So aspirating might be a very good shout. The nose is going to be an obvious high risk area, nasolabial folds, the forehead, and last but not least, the periorbital. Now, it's one thing I find very bizarre actually is the nasolabial fold, and I'm not sure if some of you can agree, but in a lot of training courses around the world, not just here in the UK, the nasolabial folds are taught on the first foundation course, and I really disagree, and I think that should not be the case. You know, because a lot of the reported complications are from the nasolabial fold, and that's because of the facial artery, which runs in very close proximity. And when you look deeper into the literature, you'll see that a lot of the cases of blindness that are happening, the patients that they're happening to tend to be Chinese or from the Far East rather. And that's because a lot of the work that's done in that part of the world tends to be focused centrally on the face, whether it's at building a nasal bridge, whether it's lips or chin, because they tend to be quite flat on profile view. Whereas here in the Western world where we are, we're too busy focusing on high arch cheekbones and lovely jawlines. So, you know, the more lateral you are in the face, as a general rule of thumb, you tend to be safer. So you will tend to see a lot more complications from patients from the Far East. Needle versus cannula. So there is no right or wrong answer. And going back to that study done by Katie Belesne back in 2015 and again in 2019, I believe there were a handful of cases that were cases of blindness or visual disturbance from a cannula. So for any of you that think that I'm using a cannula and nothing's going to happen to me, well, you know, keep dreaming, because it may. So a cannula doesn't mean you're safer. Okay, yes, it reduces the risk ever so slightly, but the complication can still occur. And for me personally, I'm a needle guy. Yes, I can use a cannula at a very high level. I can use a needle at a very high level. Personal preference tells me I like a needle. Reason being is I know where the tip of that needle is every time I'm injecting, whether I'm subdermal, subcutaneous, whether I'm on periosteum. And that pinpoint accuracy that I get with a needle, that precision, I don't think you can get that with a cannula. So that's just personal preference. Having said that, you know, I do agree that a cannula does ever so slightly reduce the risk of you having a complication. However, if you end up having one with a cannula, the only way it's going to happen is because the cannula has literally cannulated the vessel. So, you know, the chances are that that complication that you're about to have is going to probably be the worst one that you're ever going to see. So, you know, the complications with the cannula may be less, but they tend to be more severe. Okay, and it also depends on the risk of area. So, you know, as a general rule of thumb, if you're going to be injecting the periorbital or the infraorbital region, yes, use a cannula. And the 25 gauge as a cannula is the ideal choice. You know, studies have shown that a 27 gauge almost mimics a needle. So 25 gauge cannula is your best shout. Personally, I think putting in a 21 or a 23 is a little bit harsh to the patient. And with a 25, you don't even need lidocaine. You know, quick entry point and off you go. So remember, it always depends on the area to be injected and the depth. You know, the most important thing when it comes to facial aesthetics is depth. How deep are you in the face? How deep is your needle going? How deep is your cannula going? Now, most of the time, if you're on periosteum, not all the time, but most of the time when you're on periosteum, you tend to be safer. Okay, so if you're going to be injecting a little bit more superficial, well, guess what lies more superficially? Or the majority of the vessels. So maybe if you're going to inject something a little bit more superficial, use a cannula. If you're going to go deep onto periosteum, go deep and use a needle. So this is probably the biggest debate I believe there's probably ever been in facial aesthetics, and whether you aspirate or whether you're not. And before I put anything up on the slide, I never aspirate. You know, whether I'm doing the nose, the temples, anywhere on the face, I use a needle, I never aspirate. And it makes me a bit of a hypocrite, actually, because I have got a teaching academy here in the UK, and whenever I'm teaching, guess what? I teach them to aspirate. But, you know, I think the whole point here is know your anatomy, know the depth that you're in, pick the right tool, the right patient, be at the right place at the right time, and then inject to your heart's content. So I don't feel aspiration has a rule. And the lay analogy to this, before I give you the actual evidence-based, is think of it this way. On the cover slide of today's webinar, there was a face. You see all the red vessels of the face. It's actually from Amsterdam. And what you'll see is that the face is very vascular. Now, the moment you're putting a needle into the face or a cannula or whatever, guess what? You are entering into a vessel and bursting it, essentially. Now, think logically. Just because they don't bleed and you don't see anything or they don't bruise doesn't mean you've not burst anything. It's probably very impossible. Okay, I would probably even say it's impossible outright that you're not hitting a vessel. As soon as the needle goes in, you're going to be hitting something. And what will happen is you're going to get a bleed. And so the intravascular blood becomes extravascular into the interstitial surrounding. And so that when you aspirate on the plunger, how do you know, this is my question to you, that aspiration is coming from the surrounding blood or it's actually intravascular? You have no idea unless you've got some fancy ultrasound gadget. So that's looking at it from a lay perspective. And then now looking at evidence-based. So there was a study done, this is fairly recent, 2018. Okay, so just a couple of years ago by Van Loghem and his colleagues, 340 aspiration tests. And they were done with different types of fillers and different needle sizes. I believe there were 24 different types of needle sizes and 340 tests. And so look at these facts. 112 were true positive aspirations with blood, obviously, within 1 second. And there were 128 false negative after 10 seconds. So between 1 and 10 seconds, only 101 tests were positive. The thing to take away from this is the first part of those bullet points here. 112 true positive results within 1 second. So as soon as you pull the plunger back, only 33%, right, had a true aspirate. And if you look at the line at the bottom, positive results between 1 and 10 seconds of aspiration was only seen in 101. Now look at those numbers and compare it to the first number on the slide, 340. So what does this mean? Now, this doesn't mean, oh, all of you who are aspirating all of a sudden should stop. No, what I say, and this is what I say when I'm teaching, is aspiration, it may put you at sleep tonight to an extent. But what it should be is a additional tool to your current skill set. So what you should be looking at is when you're injecting the patient, you've got the right patient, the right product, you've done your homework with the anatomy. And when you're injecting, you're looking at the surrounding skin. Because what's the first sign that's going to happen when you have an occlusion? Blanching. Then there's going to be pain. Then there's going to be color changes. There's going to be reduced capillary refill. So therefore, as you're injecting, always keep your eyes on the skin and on the patient. Okay. Then, once you've done all of that, if you feel the need to aspirate, then aspirate. So, you know, aspiration, it has value without a doubt, but it should be the last thing that you rely on. What I say and what I disagree with is if there's any of you that are aspirating, you put the needle straight in, you aspirate, it's negative, and you carry on, you're going to have a negative result at some point, without a shadow of a doubt. And it's like driving a car from a young age to old age. You might be the best driver in the world, but you don't know what other drivers are like. And the same way, we don't know what the patient's like. There's a lot of anatomical variance amongst faces. So, you know, the moment the needle goes in, if you're only relying on the aspiration fact, but you've got no concept of looking at the skin, looking at cap refill, looking at the pain, asking the patient, get the feedback from the patient. What's the pain like? Okay. If they start off with the pain being a 12, then, you know, you just got that type of patient. We all have one. But, you know, to try and suss them out, you know, it's teamwork. So that's a very interesting study. Like I said, it was only done a couple of years ago. Blindness per se itself, it is rare, and it's being now what we call, it's got a classification of its own, and there's type 1, 2, 3, 4, and type 1 being, I'm going to say in quotation marks here, a mild version. So it's blindness without ophthalmoplegia. Ophthalmoplegia basically means paralysis of the extraocular muscles and weakness, and it's also associated ptosis. And then you have all the way down to type 4, where you've got visual loss, you've got ophthalmoplegia, and you have ptosis. And what you'll find is, as you may have one or two cases around the world whereby there has been a recovery of sight, but in the grand scheme of things, you should still have the thought process in your minds that no, it cannot be reversed, because if it was reversed, there would be a proven protocol and a hard copy written out everywhere, but there isn't. And what do you do if there is blindness or impending blindness? So the vision is going, and how do you know what the vision is going? Well, there's something called the VPL. VPL stands for the visual perception of light, and essentially that's what you're trying to ask the patient. Are you still seeing something? Is it a bit blurry? Is it a bit hazy? Are there some spots or floaters, etc.? Or is your vision totally gone? Is it just completely black? Because that's telling you at what stage they are at. And the chances are, if the vision is blurry, a bit hazy, etc., and you get them to the right person at the right time, usually within the hour, then something may potentially be done. Whereas if they have no VPL, so there's no visual perception of light, then there may not be any hope, and praying is your only option. So some of you have heard of retrobulbar injections. Are they good? Are they bad? Should we be doing them? Yes or no? So it requires skill. Okay, I'm not sure if any of you have seen it being done before, but it's definitely not the easiest thing to do, and it probably would make some of you squirm without a doubt, because essentially you're injecting into the posterior medial aspect of the orbit. Now, a lot more studies do need to be done, and a lot of harm can be done. I think there's a bit of a typo in that line. Can do more damage than harm. So you get what I'm trying to say here. So you can do a lot more damage than benefit to the patient. A lot more studies are required, and there is an element of toxicity to the retina. So on one hand, we've got a high dose protocol, which I showed you earlier on, which means you're flooding the area with hyalase, and then all of a sudden, there's an element of toxicity to the retina too. So on one hand, you're trying to save the retina, but on the other hand, you're putting something in which may cause further damage anyway. So it's a bit of a gray area at the moment, and the best thing that you can do in this scenario is an emergency referral to ophthalmology. And that's because they're going to be the experts, and this is something experts should do, so let them deal with it. And there was a study done back in just a year ago, actually, by Hwang and his colleagues, and they used 8 eyes from a few rabbits, and some of them had 2 partial occlusions, the others, there were 4 complete occlusions. So although 8 eyes were used, there were 6 that they used for the study, and the other 2 were a control, and they put 1,000 units injected half an hour after the occlusion, and only one of the partially occluded eyes had slight improvement. However, I mean, I don't have the facts here. Off the top of my head, when I read the study, I believe after 2 hours, there was no further improvement. So actually, it didn't really do anything in this small study. Okay. So where does that leave us? Well, quite simply, prevention is better than cure. And what do I mean by prevention? Well, know your anatomy. If you know your anatomy, then the chances of you having that occlusion is going to be a lot less. And again, don't bog yourself down on certain things like, should I use a needle? Should I use a cannula? Some of you have only been taught with a needle. You know what? Go out, learn with a cannula. And some of you have only ever learned with a cannula, go out and learn with a needle. The amount of colleagues that say to me, oh, I would never touch a needle. Well, you know, you're a good practitioner, then that's very good. But the best practitioners, they can use anything that you give to them. And also the best practitioners know their anatomy. And that's something that can't be stressed. And especially during this period of global lockdown, this is a nice time to try and get through that knowledge base and building your anatomy. Just as a very little recap of anatomy, this is from previous slides. One of the things to note in the face is that there's anastomosis between the internal and the external carotid system. And this happens in more than one place. There's also anatomical variations, which I've gone through in the previous webinars. And the last thing here, as I've stressed quite a fair bit today, is the injection depth, that D word. You know, it's the most important thing when it comes to facial aesthetics, whether you're augmenting, beautification, enhancement, rejuvenation, you know, creating a lift in the face, whether you're doing skin boosting, it's all about knowing what depth you're going to be injecting into. So that does bring me to the end of the complications webinar. Hopefully that was quite enjoyable and useful to some of you guys. Like I said, normally I run a course that's around 7 or 8 hours long. And a lot of you here watching today have seen me do this course, both here in the UK and abroad. You know, so it is difficult to try and put everything down. I think that was just around 45, 50 minutes. I will say that in about 2 weeks' time, I will be running an online facial aesthetics anatomy webinar. There will be a small fee, obviously, but I will be covering full face anatomy from top to bottom in a lot of detail and very clinically relevant. So this will be probably done in the next 2 to 3 weeks. And I will also have another webinar, which is on complication management in a lot more detail than what I've just gone through today, with proven protocols and so forth. So in around 2 to 3 weeks' time, there'll be an online facial anatomy course and an online complications course for a very small fee, but you will be certified afterwards. So stay tuned on social media. Here's the links to Instagram. And last but not least, these webinars will be uploaded onto YouTube. Some of them already are. This one will be uploaded on YouTube tomorrow morning. So hopefully that was all very enjoyable. I'm just going to stop the screen so you can see me, and we'll get through some questions. Right, so let's start with the questions. Hi, Deborah, you're asking some HA comes with lidocaine. Yeah, a lot of brands now put lidocaine in the product, but it's not enough to numb the patient completely. So when they have a vascular occlusion, they won't have any pain whatsoever. You know, when you're doing a dental block, you're blocking a larger branch of the nerves, for example, the infraorbital or the mental, therefore they're less likely to have that pain element. So, you know, it's a good thing that HA fillers do have lidocaine in them. Hi, Theodora. Do you give your patients an informed consent to sign? And if so, could you please give us a prototype we can use? Where are you watching from, Theodora? And if you find me on Instagram, then send me a message and I can see what I can do. But yes, it's, you know, routine practice, and I think it should be the case wherever you are. You not only do you need informed consent, but you also need written consent and pictures. You know, never touch the patient without pictures. Right, so there's a lot of questions here, guys. I'm having to scroll up, so just bear with me. Okay, Theodora, you're from Greece, no problem. Just send me a message on Instagram and I'll let you know. Right. Hi, okay, so Vivek is asking, will lateral movement of the cannula be easily reduced? Should an artery be cannulated? Could you just rephrase that question, Vivek, what you mean with lateral movement of the cannula? Once an artery is cannulated, it's going to be very difficult to get that cannula back out of the artery without obviously pulling it out. So I think once you're in, you know, you're going to be in, so to speak. You're welcome, Karen. No problem, Ashley. Dr. Carla, thank God in my 15 years of experience, I've never had complications with the use of fillers in general. You're very blessed, doctor, if that's the case. So keep it up. You must be doing something right. But it's nice to always be aware of, you know, certain complications and how to manage them. You're welcome, Eva. Thank you, Carla. You're welcome, Vivek. Hi, Kathy. I was waiting for a message from you. Does the blanching you get during a VO look different to the blanching seen on the skin from the lidocaine in HA? No, look, blanching's blanching. Okay, so it's going to be a very similar type of blanching appearance, but keep in mind it's very short-lived. Often you'll find it only lasts a few seconds, if that. You're welcome, Sushma. Do you apply ice packs straight after the treatment? Example, lips. I use cool packs, but there's not sterile, so always a little apprehensive of infections. No, not necessarily. I will always say to the patient that, you know, expect a little bit of edema. I mean, you've injected quite a few injections, I'm assuming, in the lips. It's a very vascular area. There's likely to be a bit of bleeding and a bit of edema going on. So, you know, our job isn't to, you know, shut that down completely. That's your body's natural response, inflammatory response. So if the lips are swelling too much and it's a bit of a concern for the patient, yeah, then you can advise when you get home, put an ice pack on. Sometimes what you find is when they put an ice pack on straight away with a bit of pressure, they may cause a slight migration of the product. So it's not a necessity, but it's a potential add-on. Hi, Vivek. Usually it's easier to move the cannula from left to right, but the ability will stop should the cannula be within artery. I'm still confused what you're trying to say. I'm assuming what you're trying to say here is if you're using a cannula and coming from a lateral approach, going medially, yes, that's going to be a slightly a lower risk of cannulating an artery. For example, if you have an entry point over here, lower down in the face, and you're going up, the chances are you may hit the infraorbital foramen or the angular artery or the facial vein even. So yeah, if you have a lateral aspect to the cannula, okay, so if I'm doing tear troughs, I enter laterally. If I'm doing cheeks, I will still enter over here and I work from lateral and I go down medially. Okay, Kathy, so what do you use for warm compress? How do you keep the area septic while injecting hyalase and massaging? So basic infection control measures, you know, you obviously use of gloves, chlorhexidine or Clinisept, you know, you're doing your best here. And I think if they have a vascular occlusion, I mean, I'm not trying to say infection control isn't important. It's probably one of the most important things. But in that moment in time, if they have a nasty occlusion, your main priority is get the hyalase in, you know, and I'm assuming you would have your gloves and basic measures of infection control in place anyway. So I wouldn't worry too much. What you don't want is that filler to dislodge and you end up having necrosis, worst case still visual disturbance. Hi, Christina. What do you think about acupuncture for edema, or for example, arnica for managing hematoma? Some surgeons in Croatia practice that. And by the way, love the presentation. Thank you very much. Acupuncture for edema. Wow. Something I might have to give a go. But I think arnica is useful both in the pre-treatment and the post-treatment stage. If it's a hematoma per se, so this is a contained bruise, if you like, then it may well be just to puncture with a needle and express or aspirate. It's just so you can reduce the size of the hematoma. I think that's what you mean. And if that's what you mean, then yeah, definitely. So if it's a small hematoma, just watch and wait, it will resolve. However, if it's a large hematoma, feel free to aspirate. Applying Vaseline after lip treatment, yeah, that should be fine, provided it's sterile, so it's just for that patient, I guess, and maybe giving it to them to take away. You can get these small little tubs, I guess. I tend to use Arnicare. If you go on giovanni.co.uk, you'll see that we have a post-treatment lip balm, which is what I tend to use. and patient can then obviously take it away with them as well and continue using it to keep their lips looking nice and hydrated and plump. What do you mean, Kathy, by just a warm compress? Yep, my Instagram is here. There you go. Right, guys, I'm just going to stop the recording for the YouTube channel, and we'll spend a little longer and we'll take it from there.